Good morning, everyone. Welcome to the final session of the Nuffield Trust Summit Series. My name is Nigel Ebbers. I'm the Chief Executive of the Trust. It's the 14th summit, but it's our second online. We're hoping that we'll be perhaps back in person next year. But it's been great to widen our audience to attract a much larger number of people than we would usually have face-to-face, not just people from the UK, but across the globe. If you missed any of the other sessions, and they've been really excellent, even if I say so myself, they are available on demand. If you go to the agenda, you'll be able to look back on those. If you're not familiar with the Nuffield Trust, and maybe this is the first session that you sat in on, and you're not familiar with us, we're a health policy and health services research think tank. We look at a wide range of issues relating to health and social care policy, and the summit here is an opportunity to provide people who are working in health care and health policy with an opportunity perhaps to take a step back from some of the immediate pressures and issues of the day, and to think about some longer term issues and about some of the more challenging issues that are facing health systems both in the UK and internationally. So, as I said, you can look at the full programme on demand. It's on the platform, and we hope you enjoy this session. I'm going to thank our sponsors, who are Optum, and our media partner, who are BMJ, and in particular also our events team and the people who are working behind the scenes to make use of this. I hope you'll engage fully with this. The session is structured with three contributions, a bit of discussion from the panelists, but largely we want to try and involve thoughts and ideas from people in the audience. So you've got a Q&A box. Please use that throughout the session. If there's something that immediately occurs to you that you want to contribute, put it in there. We have a section for Q&A, particularly at the end, but if we see something that's particularly pertinent or relevant that pops up at some point during the panel component of that, we'll bring my colleague Rowan Dennison, who is going to be in the background monitoring your questions and providing some synthesis of them. At the end of the session, don't go away immediately, because we'll send you a link to an online evaluation survey. We're very keen on evaluation here at the Trust, so please help us with our own evaluation. And this is not a Chatham House event due to the fact that it's being broadcast online. So please do tweet if you're so inclined. We have a hashtag, which is #NTSummit, and give us your thoughts and ideas as they come along. So time to introduce our panelists. I'm delighted to say that we've got three really interesting people, two of whom are people who keep popping up in various stages of my career, always in slightly different guises, but always with something really interesting and original to say, and that's Tim Ferriss and Patricia Miller, and then someone who's new to me, but I've been following on Twitter and is also absolutely fascinating, which is Dr. Stella Vig. So, but first we're going to hear from Tim Ferriss, who's in his current role is Director of Transformation for NHS England and Improvement. Then we'll hear from Patricia, who's the Chief Executive Designate of the Dorset Integrated Care Board. And then Dr. Stella Vig is Consultant Vascular Surgeon, but also National Director for Elective Recovery at NHS England. And the exam question that we're really trying to ask is, what are the levers for change, both policy and practical? How are we using them? What are the issues that we're encountering as we're doing so? And what can we be doing to try and help drive improvement, change and progress in the NHS, given that we've moved away from some of the traditional mechanisms that we're used to use, and we've got perhaps a more mixed methods approach to doing that. So without further ado, I shall hand over to Tim to give us his opening thoughts. We'll have a bit of unpacking of those, and then we'll move on to Patricia. So Tim, welcome, and over to you.
Nigel, thanks so much for the invitation to be here today. Looking back, I think actually it was an invitation to this conference that was my very first interaction with the health system here in the NHS, I think over a decade ago. So it's a real pleasure to be back here I could never have predicted then that I would actually be working in the NHS at this time. So I was asked to sort of address three questions. And the first is the my preferred theory of change model. And I'm going to pick up on something you said right there at the end, Nigel, which is there isn't one change model that is successful. I refer here to Isaiah Berlin's The Hedgehog and the Fox, that famous essay in which the hedgehog knows one big thing and the fox knows lots of little things. I think when it comes to change, the fox is probably better than the hedgehog. That a singular approach, particularly in healthcare, is unlikely to be successful. So while it's an aspiration, I think you need to fit the change you're talking about to the particular circumstances. And then I'll cite Everett Rogers, a hero of mine, and the author of The Adoption Curve, and use the approach that fits. It fits the people who you're working with, the change you are trying to make, and the point in the adoption process at which you are. And so the people you're working with are going to have different things that motivate them. You have to make sure your communications align with those motivations. The change you are trying to make, you would approach a new therapy very differently than you would approach a new organizational chart. And then the point in the adoption curve, as Everett Rogers wrote, early, middle, and late. So all of those you have to have a bespoke answer to that generalized question. There is an expression that I found particularly useful in change across large organizations, and that is this expression: jointly decided, centrally supported, locally led. I'm going to go into those in just a little bit of detail. Jointly decided. So people must be provided agency. But the challenge is that making sure a decision is actually made. So too much agency spread across too many people, and it lacks a decision. So it is a careful application of executive authority in the context of an inclusive process. That's jointly decided. Centrally supported, the role of the center is to help get through the tough jobs of delivering where change actually happens, and that is locally led. And then the last point on my preferred theory of change is the learning health system. This whole idea of data to information, information to action, and action to data. I've seen brilliantly throughout the NHS since I've been here 9 months that different pieces of that action wheel, but it's what I think we need to do quite a bit more of is make that action, grease that wheel to turn more deliberately, so that every part of it is actually working together to produce the kinds of innovation that we need. So number two, I was asked for the hopes for what I might achieve. That was a really interesting question. I would like to say it's demonstrably better collecting and demonstrating and dissemination of data, demonstrably better delivery of high quality health services and improved outcomes, demonstrably better at integrating health and care, demonstrably better at working together, shared purpose and mission, demonstrably better at workflow and productivity, less administrative friction, demonstrably better at supporting young clinicians, entrepreneurs, scientists, and managers in career aspirations that they can really look forward to and engage with, and demonstrably better at incorporating innovation from both inside the NHS and outside, with commercial partners and other partners that are developing the science of innovation at a time when there is so much great science to be incorporated into healthcare. And then my closing point, I was asked to comment on moving from being a clinician to being an administrator in a very large quasi-governmental organization. And I guess reflecting on that, I would say the honor of having a skill that strangers value and seek guidance for because they are suffering, and that who they place their hope and trust in. It's an extraordinary honor. It's also an extraordinary honor being part of a senior team entrusted with developing and disseminating policy and guidance to shape the infrastructure that clinicians will rely on to deliver the best quality of care. Both, of course, have their frustrations, but more importantly, both have the opportunity to make life just a little better. And I'll close with my favorite quote, which will leave I'll leave hanging the source of the quote, which is, "Take the fruit and let the chaff be still." So with that closing cryptic line, I'll turn back over to you, Nigel. Thanks.
Thank you. Yeah. One significant difference, I guess, you've come from a big health system, but the NHS is rather proud of how big it is, and I've often wondered that being an outlier is not always a great thing. It's very big, it's very centralised, and actually even other NHS systems in other countries are run on a more regional basis, and perhaps what we might say is a more human scale. Do you think there are particular challenges of that sort of very large scale? And does it bring any advantages that you can see? And if there are problems with it, how do you mitigate those, do you think?
Great question. So I think there is something about scale that is highly advantageous, and that is deployment of resources. So one of the main functions of the center is that infrastructure can be deployed much more cost effectively. And so famously, right, the percent of GDP spent on healthcare in this country is on the lower end of the OECD scale. And so I think it's widely acknowledged that the NHS punches above its weight for the resource allocation that it receives. And part of that is the fact that it is a large organization, and it could use that weight, its own weight and size, more effectively. And I think there are plans to do that. But of course, Nigel, the other side of that coin is the sort of the weight of that infrastructure imploding on itself, and the degree to which local authority and autonomy can be significantly undermined by too much center. I think getting the balance right is really, really important and tricky. One of the things that I think is an ingredient of that mitigation that you spoke of, that you asked me about, Nigel, is large organizations need more connections into themselves. They need to not function in their organizational silos, but connect between those silos much more frequently, much more broadly. That is one of the mitigation strategies. The other mitigation strategy is we definitely need to empower and enable and support more authority and autonomy, as I said, locally led, jointly decided, centrally supported, locally led. We can do more on the central support for the front rather than performance managing from the top, but actually supporting. And then actually having a model that makes it clear where authority is local. And there are plenty of opportunities to do that. Let me just also say, in closing, Nigel, one more point, which is, again, back to my theory of change. You have to break it down by what it is you're talking about. This one opportunity that this country has that it has not nearly taken full advantage of, but the pandemic showed really clearly, is how we could use data flowing into central repositories that allows us to analyze exactly what we're doing well and what we're not and where we could improve. The vaccine program is a phenomenal illustration of where having that organizational and countrywide approach to data turning into information and information into action was an enormous advantage to this country. And we could do that in so many more clinical areas than we currently are.
You've made an interesting distinction about, well, in my mind, actually, I think there is a distinction between data for performance management and data for improvement. You put a lot of emphasis on data that you put in the learning system, but my observation would be that the NHS has got perhaps the wrong end of the stick in some of its approach to performance management, and you seem to be suggesting a different. Is that am I putting words in your mouth with that, or is that would that be a correct?
I'm happy to have those particular words put in my mouth. So yes, I'm agreeing with you.
So the other point that's in my mind listening to this is the management theorist Henry Mintzberg observed that healthcare organisations around the world often have a concrete floor between the clinical front line and the people managing it, and that's even within quite small organisations. So that the clinicians at the front line have the policymakers change incentives, issue policy documents, and send out directives, and the clinicians sit there with that age-old motto, "This too shall pass," and just get on with their clinical work. Yeah, any thoughts on? I mean, that's even more of an issue in such a big organisation. Any thoughts on that?
Well, I'll use an example. The most rapid change that I have ever seen in a large organization is when the administration and the clinicians were together in asking for and enabling a change. The administration paid for it, and the adoption was extremely rapid. And let me just say, it was because that it was unambiguous that what was being adopted was better patient care. It was going to lead to better. There was no or extremely little disagreement. And then it was pushing against an open door. It was clearly better patient care. And so I would just say that often, and maybe I'll have an additional statement to make, which is there is a tendency in all of us, I think, to let the perfect be the enemy of the good, and I'll do what you want to do if you do what I want to do, and it coming down to that kind of negotiation. Those are the kinds of things that I think can impede progress. And so finding those things that everyone can agree on and moving forward with them is a big part of what management's job should be.
So very relevant to that, I think Stella has just sent me a bit of a question. Stella, do you want to just say what was on your mind?
Thank you, and those are very, very welcome words, Tim. The question I have is, we have allowed through COVID, and it's an allowed conversation, through COVID, individuals to innovate. But how do we support those? Because we're not going to get it right every time. How do we support providers and regions who innovate but may fail in the first pass?
Thank you, Tim. We seem to have lost your picture. I don't know quite what's happening there. You oh, right. We've lost Tim. Perhaps we'll hold on to that question for a moment and come back to Tim. Let's move on then to Stella. To Patricia, and get a perspective. Tim's back. Tim, did you hear that question?
What I thought I heard was
I think we're going to tell you what, Tim. We'll come back to you with questions from Patricia and Stella in a minute. I think perhaps when your signal is a bit more stable, if that's okay. Let's move on to Patricia. Patricia, welcome. Over to you.
So thanks very much, Nigel. So the questions that you asked me to talk about were, how did I see us driving improvements in efficiency, better patient care and experience and integrated care, and also how will that be delivered through working with partners? So I think the first point for me is the fact that I really welcome the legislation around not just integrated care and putting integrated care systems on a statutory footing, but also the new focus on health inequalities and how health and other partnerships can improve the overall health and well-being of communities. And I welcome that because I think that when Bevan originally designed the NHS, it was there to make sure that communities stayed healthy. And for very good reasons, we've lost our way over the last few years, and we've become a service that focuses on managing ill health rather than supporting our communities to live long, healthy lives. So I really welcome that change of direction. But I think it's for us to recognise that we will be in a period of transition for quite a long time. Moving the juggernaut from going left to right is going to be a complex and difficult task. But I do think that the creation of integrated care systems with the aims that are set down for them are absolutely critical to achieving some of the key elements in that first question. When we look at the objectives that have been set for them in terms of improving access and productivity within health services, tackling health inequalities, and the NHS being seen as a key partner to social and economic development, there are really key objectives there around how they then link into improving efficiency, better patient experience through a foundation of integrating care across sectors and organisations. But I think there are lots of factors that affect the health and well-being of communities. These can include the place where people live, how health services are delivered, and how decisions are made by local and national government in terms of systems, structures and institutions. But we need to recognise that only 20% of an individual's health and well-being is dictated by anything that health does in terms of intervention. 50% of it is about the quality of housing that individuals live in, and the remaining 30% is made up of education, employment, climate, lifestyle choices. So I think one of our advantages or the way that we need to work in integrated care systems is recognising the input that health will have, but also the fact that the partnership with the wider system is absolutely critical if we're going to achieve the real shift in long, healthy life expectancy that is required, not just to make sure our populations are healthy, but also to reduce the financial burden on health and care services. So I also think that health institutions have a big role to play in that wider inequalities question. We are bound by the Social Value Act that requires us to not only become good employers, employing people locally, but also that we are expected to contribute economically to our communities. And also we're expected to deliver our responsibilities around the greener agenda. And you'll be well versed with the research that the Nuffield Trust have done, Nigel, on what happens to communities when anchor institutions that are the cornerstone of the community survival disappear or fundamentally change the way they operate. And we know that within 10 to 15 years, those communities disappear. So we have a huge responsibility on the broader health inequalities question and how we are contributing to that wider agenda. But I think there's also something about the way that we work together in partnership. Having a shared purpose across a number of stakeholders, including our communities, is absolutely vital. Determining what should be delivered at a system level, as opposed to what needs to be delivered at place, and reinforcing Tim's point about locally led developments and locally led services is again a really important aspect of the way that we work together. But for me, what is the cornerstone, other than the way that we choose to innovate, is relationships and their impact on how we work as integrated systems and in an integrated way. Organisations working to the best interests of the system and communities and not what's in the best interests of their organisations, using finances more flexibly and fluidly. And in our ICS at the moment, we are having a conversation around what do we actually mean by the Dorset pound and how do we get best value out of it in the interests of the communities that we're here to serve. But also developing mature relationships that mean we ask the partner with the best skills to deliver in certain areas and not necessarily the one who's always seen that area of delivery as part of their remit. And that does require trust, and it requires a maturity of relationship that in many places we currently don't have. But for me, one of the most crucial points is how we co-design and co-deliver with the communities we're here to serve. How we really develop integrated care strategies that put our communities at the forefront of some of the decision making, and as officers we are seen as the delivery mechanism for what they need, and that will require lots of trade-off conversations around what the service can afford as opposed to what communities want. But when we think about the success of places like the Wigan deal, to me that is the key to how we move forward in true partnership with communities and building those relationships of community leadership and community capability is absolutely the centre of the how we move forward. Embracing the lived experiences of those who live in deprived communities and understanding what barriers we are creating as health and care partners to that health and wellbeing improving and changing the service offer into something that is valuable to them. I also think there's something about the way that we develop our leaders in that space. We assume often that when the NHS in particular needs to make a change in direction, that the leadership have the capability to morph into anything that we need to. And we don't give enough thought to the leadership ask, what it means in terms of skills and experience, and how we create a leadership cadre that is able to deliver that change. We will be dealing with a much higher level of complexity. Leaders will need to manage both horizontal and vertical relationships, as well as understanding what true community engagement means, and that's not consultation, that's co-design, and what that means for partnership. I think the next point for me is when we focus on health inequalities, some of the foundation for that is a real understanding of equality, diversity and inclusion. We can't, in the widest sense, we can't expect our people, our NHS people, to engage in health inequalities questions if they don't understand how that agenda is delivered inside the organisation and feel confident in their knowledge and expertise in that space. And then finally, it's about how we manage and judge performance, changing some of the way that we think about good performance. And it's not just about the hard measures that the NHS needs in order to demonstrate delivery at a political level. It's also some of the softer measures that really mean more to the communities that we're here to serve. Some of the areas that Greater Manchester have looked at, for me, are really the way that we engage communities in this agenda, personal happiness, young people having hope for the future because they see employment opportunities where they live, taking homelessness away from the streets, the way that we look at early start in life for children to make sure that they are school ready, that there are early interventions when we see children struggling with emotional attachment issues. There are lots of things we should be looking at that are softer measures that are about personal happiness right from cradle to grave. It had a huge impact on life expectancy. So for me, in summary, I think the creation of integrated care partnerships is the key to some of this. It's the key to making major improvements in life chances in our communities, and the NHS has a huge part to play in that. But I also think the NHS needs to make a fundamental change to the way that it operates. It sees the world through a very narrow lens. And if we're going to make these changes, we have to think much more broadly. And there are two things that really stand out for me when we look at integrated care and how it's been delivered overseas. where it's been delivered successfully overseas. One is the flattened structure. The NHS loves a bureaucracy and hierarchy, and if we're going to really deliver and make people accountable locally at place, then we need to flatten the structure that we have and be brave around that. And the second point for me is how we really develop local leadership and clinical leadership to be at the forefront of delivering the change that we need to see.
I'm afraid, thank you, Patricia. I'm afraid I got booted out of the conference platform just as you were making your first point. So I think I missed it, but I won't ask you to repeat it for my benefit. Perhaps one of my colleagues will stick it in the in the chat. I mean, what I did hear you, however, listing was a great list of really interesting ways of measuring. Of where to focus and how you might measure success. I mean, I must say, if I sat in local government, I might be thinking, hold on a minute, this is my job, isn't it? So does this call for a different way of because the NHS has had, I think it's fair to say in the past, a bit of a tendency to feel like it's taking over things. So, it is the 800, the proverbial £800 gorilla, if you remember, which sits wherever it likes. But is that something that's on your mind? And is that an important part of the sort of recasting some of the relationships that you were talking about?
I don't think it's about taking over, Nigel. I think it's about us recognising that we have a contribution in that space. Mm-hmm. And if we're going to keep local government at the table and engaged going forward, whether it's in the ICB or the ICP, then we need to be talking about things that are important to them. And our contribution to really delivering on the local government agenda. And I think that we have a huge part to play in that space. And I think that we haven't done what we should have done in the past. And when Simon Stevens talked about the NHS being the biggest anchor institution in England, that's where our minds and efforts need to be, because as I said, only 20% of a person's health and well-being and long, healthy life expectancy is about what health does, as in its physical intervention. Yeah. But there are other ways we can use our power as organisations and our capability to contribute to that wider inequalities agenda, and we should be doing that.
When I got booted off the system, I lost a question I think you had for Tim, but I might almost ask you the question, if I remember it rightly, which was, it seems like you're implying there's some quite significant challenges for how leaders in these systems think. But so I'd like you to perhaps expand on that, but also to perhaps reflect on the fact that they're still living in a world where quite a lot of the NHS is organised on verticals. So there's a mental health vertical, there's an elective recovery vertical, there's an emergency vertical, there's cancer, there's these different, we've got these very sort of vertically organised approaches coming down, but what you seem to be describing, I think sounds really appropriate for what you're trying to achieve, is a much more population focused, holistic. And this is a dilemma many health systems have, is that if you focus, but if you only focus on the verticals, so I discovered working in Central Asia, HIV and TB control is fantastic, but everyone's dying of coronary heart disease because you haven't actually got a proper delivery system. So you're just managing that tension, the tension between improvement and performance, and between verticals and community, and what that means for the leaders in your system, I think would be. And then we might just get Tim to reflect on that question as well, if we could.
Yeah, I think it's complex, and one of the things we were talking about yesterday in one of our system meetings is how we map, some of the alliances, the networks, the partnerships, and then really start to understand how we can engage with all of those to make sure that we're not having discussions and making decisions that are at odds with each other. I think one of the really positive things is the development of specialist commissioning into ICSs, because then we're cutting out one of the contradictions we've got now, where specialist commissioning deals with half of the service, local commissioning deals with the other half, and never the twain shall meet in terms of agreeing one strategic direction for that service. And so I think we're going to have to deal with a level of complexity. But I also think that the NHS quite often has organised itself around what makes sense for the organisation and its infrastructure, not necessarily what is in the best interests of communities, for a whole range of reasons that are not all bad. But I also think we've taken quite a paternalistic view for a long time in telling communities what they need, what they want, and what we're going to give them, as opposed to asking them what they need and what they want, because then we're creating more mature relationships, and we're encouraging members of our community not just to take responsibility for their own health, but also take responsibility for how resources are spent and used. And I think we've got to trust them more in terms of understanding themselves, what their lived experience is, what they need, what we can do to meet those needs, and also trust them then with directing us on what is the most important things to spend NHS taxes on, rather than us always being in the front seat of that decision and not doing as much real, true listening as we should do. And I think Wigan's proved that if you take a different approach to the engagement of communities, you get a very different response.
Yes, thank you. Tim, I don't know if you wanted to come in on that particular point. If you don't worry, but we'll unmute you.
Can you hear me?
Yeah.
Yeah. Okay. Yeah. No, I think it's Nigel. That is the core irresolvable tension, isn't it? That you're describing. That you know, often siloed approaches, which you could also call specialties in healthcare, are the shibboleth, the stalking horse against which all is a source of challenge in the delivery of healthcare. But we do have to remember that it is actually through specialized knowledge and the delivery of services within a distinct area that science advances and care advances. And so we can't do away with the specialized knowledge and the advancement of that specialized knowledge, clearly. And so what is the structure that is going to balance that, that the important progression of specialized knowledge in, for example, the learning health system, with the delivery of services in a holistic way on the ground that meets the needs of the population? And we are about to embark on a extraordinary opportunity, I believe, with the ICSs and ICPs to have those bodies actually get the balance right between those, because I think that is their remit. And so I'm excited. It's actually one of the reasons why I came here from across the pond, is because there's nowhere in the United States where that kind of joined up governance at the place level and the ICS, ICB, ICP level. There's not even a hope of doing that. Whereas here, there is actually a plan to make that the driving force behind the allocation of resources.
I guess I was kind of getting at the risk that the way that we're kind of managing at the moment through some of the vertical programs does mean that there's a job for the ICS to do in terms of trying to reconcile those tensions. But I'm conscious of the time, so I'm going to move us on and come to the sort of some of the one of those particular clinical areas, which is to hand over to Stella. And hear her perspective on the questions that we've given her. And then just remind everyone, if we could, there's a questions box. Please put your thoughts and ideas in that, and we'll pick up any of those. I've been looking at those and picking the odd one up as we've been going along. But Stella, over to you.
Thank you, Nigel, and Tim and Patricia for setting the scene so beautifully. So, Nigel, you gave me some difficult questions. So you asked me, how do we get clinicians engaged practically? And you asked me what changed on a Monday morning, and I've converted that into what's changed during COVID. So COVID, as we know, significant impact, has really changed the landscape in which we work. But Tim, to your point, it is unleashed innovation, and it's unleashed innovation at the front line. It's allowed us some headspace to think, some finance to be able to implement change. And the centre setting a vision that we need to make sure that vaccination hubs are set up and we are delivering, that we need to stop all elective and actually manage COVID, that we now need to refresh and get elective going. The centre's vision is really important. But Tim, you're absolutely right. The local design, local ownership, local understanding and local implementation is what is getting clinicians. And that's clinicians, Patricia, you talk about community, that is people in the NHS across the entirety of the NHS. It cannot be that the local design and implementation sits just with secondary care or primary care. This has to be whole system change. And the changing roles in COVID, the kind of lessons that we need to learn are the very early transformation in outpatients, how digital has been incorporated, how I've spent 5 years trying to get rid of paper notes in outpatients at Croydon. And we have always gone back to the consultant knows best. And therefore we need the paper notes in clinics because that's how I get the information of all my patients. But actually within 3 weeks, we'd got rid of paper notes at Croydon completely because we realized that we didn't need them because we had the digital strategy to do what we need. So actually really challenging conversations have been enabled because of COVID, and we mustn't lose that ability to change. There's been changing guidance in surgical interventions, which have been appropriate. Do we treat appendicitis with antibiotics, or do we just wait because they're COVID positive? Do we manage more patients under a block or local anaesthetic rather than general anaesthetic when we've been really struggling for HDU and critical care beds and day surgery beds? Do we increase self-care? So, for example, podiatry and stoma care, we now empower patients to be more self-caring, more self-reliant, and actually use the resources around them rather than the medical models of care. Haematologists are now delivering chemotherapy at home, which we thought would never happen in the volumes that it is now. And at Croydon, as well as national guidance, we've separated elective care and emergency care, and we know that the sites that have changed and supported that separation, where we can really concentrate on delivering both well rather than both together potentially not so well, has really created change. So Nigel, your question is, how do we get clinicians engaged practically? Well, you give them a little bit of headspace. You stop talking about 6 million people and we start talking about individual patients, because that's where we come from. We want to make a difference. And we understand, and we have to rely on our workforce, but we need to understand, how do we support our workforce in working differently and flexibly to do what we need to do? So the 3 levers for change for me in terms of getting clinicians engaged, Nigel, are the freedom to innovate, the freedom to fail, which is the question I wanted to ask Tim, but also the freedom to adopt and scale. And I think they're going to be vital in terms of the NHS reset and recovery. The second question you asked me was, what's different for the patient? And Patricia, you've said it beautifully. We've been taught as doctors to ask, what is the matter? And Ed Kinsella, who is the lay chair for the Royal College of General Practice, said the other day, we need to stop asking what is the matter and ask what matters to patients. And I think that is a fundamental change in the NHS now. Patients want to know. If you talk to patients and you listen to patients, what they want to know is, where are they on the waiting list? What information do they need to be able to do what they need? Because they feel like they're being forgotten and they feel that they've become the mass of the 6 million. So how do we give them the individual information that allows them to do what they need to do with their lives? We need to ask patients what matters to them in terms of how service is delivered. And the recurrent conversation is, patients don't want to rubber stamp, and organisations don't want to rubber stamp the centre's decisions. They want to be co-designing. Tim and Patricia, you both said the same. Co-designing the services that are provided around them. So if we have community diagnostic centres that are going to increase the ability to provide investigations and tests for patients on cancer pathways, non-cancer pathways. Where are they sited? Are they in areas of deprivation? Are they in areas where there's inequity? Are there bus routes to allow patients to get to where they need to be? And particularly if you say that 20% of healthcare is what matters to a patient through their lifetime and everything else is around them, well, we need to listen to patients. Patients are now making active decisions about their care. They're making active decisions to delay care because they're on a 0-hour contract and they need to earn the money and therefore can't come into hospital. They're on a 0 hours contract or in a community or an organisation that is only just now getting back on its feet. And therefore it's not the right time for them to go into hospital. But how do we have that shared decision making throughout that patient's journey so that we support them and deliver care perhaps in the evening, at a weekend, during half term, through summer holidays, where patients can take the healthcare offers that are there and make sure they're aligned to their need. But the shared decision making ensures that we are not creating inequality and risk in their care. And lastly, Nigel, you asked me about shared decision making, and I think shared decision making now has got to be fundamental to everything we do. The medical model, which is acute care knows best, and primary care surrounds acute care, is the wrong model. Patricia, you talked about community. Community is important. If we're referring a patient, if a patient needs advice, is secondary care the right place? Or do we talk about social prescribing in community, in areas that are around them? If we are referring patients in, then how do we empower them to manage their conditions and signpost back into services as they need to? Where are the patient navigators to support these individuals who may not be digitally enabled to have the same equity of care as everyone else? And if they do need treatment, how do we empower patients to improve their outcomes so they don't wait on a waiting list, but they become ready for treatment and optimize whilst on a waiting list? So I think that the last thing I want to say, Nigel, really is that the shared decision making, all the conversations that we're talking about at the moment, the levers for change, the change from performance management into performance supportive organisations, there is a national reset that needs to happen for our national treasure, which is the NHS. And that's the patient, the community, primary care, acute. But that change partnership of how we deliver care now is going to be fundamental, Nigel, to everything that we do. So, Nigel, I'll stop there if I may and come back to you.
That's fantastic. I mean, there's a common theme that's run through that, which I think you very powerfully encapsulated, which is the NHS has tended to use the quantitative measurement of things, followed up by a variety of shouting and telling people what to do as its major change management model. But I think what all three of you seem to be saying is actually the quality of the relationships and the way that people interact is probably much more important. The other interesting implication is that actually the quality of the decisions is probably as important as the number that are taken, and we tend to only count the number. Although in general practice we're not even counting that very often, but these are quite significant shifts, and I do wonder whether the sort of a large and traditional hierarchy is quite ready for that, and particularly your question that you were going to ask Tim on tolerating failure and experimentation all seem like very significant cultural challenges. I'm going to go to Rowan Dennison, my colleague, who's been looking at what you'll notice I'm not letting you reply to that, but do feel free to come back on both those points if you wish. But I'm keen to get the audience perspective. Rowan, do you want to tell us what's bubbled up while that conversation's been going on?
Yeah, thanks, Nigel. We've had a few really interesting questions. Actually, I'll try to sort of pick up on a few themes that have come up, and it might be that some of you sort of answered to some extent so far. So I might ask a couple of you to input on them. So we've had a really interesting one from David O'Hagan, he's a GP in Liverpool, and he says earlier in the week, Amanda Pritchard said that purpose is the most important factor in integrating care. So how important is structural and statutory change in achieving the aims of the ICS project? And to kind of follow up on that, how do we really integrate to reduce social inequalities, which are perhaps more in the realms of local government control, as I think Nigel and Patricia were discussing earlier? Does it need a bill and 3 white papers, or could it have worked with the law and structures that are already in place?
Who'd like to take that on? Patricia, can I throw that at you?
Yeah, well, personally, I don't think it did need a bill, because it's not about structural change, it's about relationships and the quality of relationships. But what I do think is the changes that are proposed in the Health and Care White Paper a few days ago about the changes to Section 75 that enable health and local government to use money more flexibly across sector boundaries is a really important step and a good lever, because it enables us to think about what the public pound really is and how we can use it to best effect together. So I think that change is important. But, you know, sometimes the reality is people don't always want to work together, and you need a lever like legislative change that moves them in that direction. Yeah. So for some systems that probably was necessary. But I still think it's about the quality of the relationships across sectors that enable people to develop a shared purpose and then work through what can be delivered through locally designed services at place. And if we all have that shared purpose, then we get into a conversation about it not being that important about whose remit different things sit in. It's more about working together to deliver the aim that we all agree is the priority.
Yeah, thank you. I don't know if for Tim or Stella, if you want to come back on that, you're welcome to. Otherwise,
well, I might say,
okay. Yeah, so don't have to, because we've got other questions. You're on. We got you on, Tim. It's all right. We can hear you.
Okay. Well, I might just say, you know, this is a challenging thing, and I'll connect that question to the earlier statement about freedom to scale, and it is actually a challenge because we do want local autonomy and authority, and that is what motivates people and binds them into the productive relationships. But I'll just give an example. So I was at one trust the other day, and they had a brilliant innovation that seemed like if we could scale it across the country would address a really terrific, a really intractable problem, and everyone would benefit it. But when suggesting that there was a different innovation addressing a different problem that might be beneficial to that trust, they said, oh, well, no, we'll figure out our own solution to that problem. And so we do have to come to an understanding about how in a shared, and this maybe goes to the shared vision issue, there needs to be some willingness to understand that there's a lot to get done in the improvement of healthcare, and it can't always be invented locally if we're going to make significant progress.
Yeah, that's been a long-standing dilemma, I think. Rowan, what else have we got?
Yeah, thanks. So it's actually something on patient care now, and this is actually a follow-up to the discussion that Tim led on at the beginning. So I might direct that to you first, Tim, if that's okay. So this is from Sonia Marianovic, who is at RAND Europe, and she's asking how important is it for the benefits of transformation efforts and innovative practices for patient care to be visible in the immediate short term, and that's in order to kind of foster adoption and clinical buy-in. She says sometimes benefits from transformation take quite some time to accrue. She's really interested in your thoughts on how to drive adoption when the impacts are a kind of a somewhat distant future.
Be interesting to hear Stella's view on that, I think, too. I often thought that clinicians respond most to things where there is immediate feedback, both clinically and organisationally. So perhaps I'll get both of you to reflect on that. Tim?
So I'll just be really quick. Yes, the answer is, in thinking about a transformation portfolio, you need to be working on the long-term enablers, which are sort of, I would say, back office. That might be a useful term there. at the same time that you're doing direct, immediate changes at the front lines that the clinicians and patients can feel quickly. And they are mutually dependent, right? Aren't they? And that's part of the art of creating a portfolio of activities, is getting that balance right. But the questioner is absolutely right that if you can't show early wins, then it's going to be a challenge.
Stella, what's your perspective on that?
So I think it's a really good question. And I think the outpatient transformation program is a really good exemplar. So what's the benefit for patients if we transform outpatients? Well, circa 5 million of the 6 million patients are waiting for some outpatient transformation. So if we can do 50%, 15% more in the NHS, but actually ask patients to use the NHS 15% less, we've got an opportunity to make a difference, especially in outpatients because of the numbers. So what's the driver for clinicians? Well, the driver for clinicians is making sure the patients get the right treatment in the right place by the right person every single time. What's the driver for the organizations? Well, that's where the performance lever comes in, that we say that we're only going to be reimbursing 85% of your follow-up activity because we need to drive the behavior that changes. And for some organizations, that's going to be difficult. But actually, that's when, Tim, your conversation about scale and adapt is, if you've got an organization that's actually got to 75% of follow-ups and have actually got the right patient-initiated follow-up and all the other drivers, what is it you can learn from that organization and put into the following financial year that actually drives the right behaviors that benefit patients? But for the clinicians, the only thing that will get me out of bed every single day is I go in and make a difference to a patient. That's the only thing I care about. And if we do that right, the money will follow correctly. And Patricia, it goes back to your point, which is that can't be about a community acute. It's got to be across the pathway. To get the clinical quality right, the money will follow in the right direction.
So big measurement challenge there in terms of measuring a bit differently what we've currently been doing, I think. Rowan, have we got time for one last very quick one? We're up against it slightly, aren't we? But
there's time for more. It's from Hamish Dibley at Bearing Point. It's actually partly related to the patient question. So there's an intrinsic relationship between purposes, measures, and methods. And having commonality of purpose rests on that being patient-centered and not organisationally focused. How then do we best determine what the best improvement methods and performance measures are to inform our patient purpose?
Gosh, yeah, complex question. Quick answer required. I'll go, Patricia, that's Tim, but you all got to be very brief. So sorry about that. Patricia.
I think it comes back to the points that Tim made right at the beginning, that one methodology won't fit everyone. And I think there's work that needs to be done within systems that really looks at culture, and then we can determine what methodologies are best for those systems that are going to help them deliver at pace and at scale.
Thank you. Stella.
Let Tim go first.
Tim.
All right, real quickly, two things. I think we should do a better job, more ubiquitously, of measuring our performance at the individual patient population level. We measure most things compared to last year, and that's not the best way to measure. I'll just say we should have a more population-based approach to measurement, which, by the way, was really shown clearly in the vaccination program, because that was all done at the population level. The second thing is we need balancing measures. So we need measures that assess our performance, but we also need measures of the things that we're worried about and need to mitigate. And here I'll just point out health inequalities. So whenever we measure anything, we should also be measuring its impact on delivery inequalities and health inequalities, because we need to get that right. And the only way to get that right is through measurement.
Great. Stella, you get the last word.
I'm going to come in very, very quickly. So I think the measure needs to be the patient voice, and the patient voice needs to be in the room every single time. And I think we've lost our way slightly with that. So one of the measures has to be the patient voice, and we need to ask patients what that voice needs to say.
Great. That's a great point on which to close. Thank you to our three panelists for really engaging and thoughtful contributions. I'm afraid may have raised slightly more questions than we've answered, but that's fine at this stage, I think. But I'm very struck by some of the major changes in the way that we think and approach change that some of what we've heard implies. I hope you've enjoyed it. Please fill in the feedback, which we'll leave you within a minute. Let me reiterate my thanks to Optum, our sponsors, and to BMJ, and to the team who've put this all together, and in particular to our panelists and to you for joining us. I hope you'll join us again for future events, and enjoy the rest of your day. Thank you.